Welcome to Basic Steps to Support Exclusive Breastfeeding. I would like to thank Mona Brown-Kettner for inviting me to take an update to the Basic Breastfeeding online course at Northwest AHEC. And I also want to thank Andy Brewer for helping us to navigate the technology to be able to achieve this training remotely. I am Georgiana Cogburn. I am the Region 1 lactation trainer or breastfeeding coordinator and have been in that position since 2005, and I'm currently doing that at the Mountain Area Health Education Center. I've been a registered dietitian for 36 years and an international board certified lactation consultant for 28 years. I've worked with the North Carolina Lactation Educator Training Program since 1996 as faculty and course director. I worked in WIC for 29 years at the Buncombe County WIC program, spending lots of my time working with parents and to feed their babies and helping them to achieve their feeding goals with their babies. And since 2013, I've been an adjunct professor at Western Carolina University in the School of Health and Human Sciences, teaching a prerequisite nutrition course for nursing students. In the presentation today, I need to let you know I have no conflicts of interest to declare, and that any products or brand names that appear in this presentation are purely for illustrative purposes and do not constitute an endorsement. As we're taping this today, many of us are working from home. We're taking calls from parents who are concerned about breastfeeding their infant, and we may even be conducting these visits via telehealth. So a goal of this training is to provide you with some tools to help parents have a successful breastfeeding journey. Today, what we're going to be looking at are the evidence-based practice techniques that will facilitate successful breastfeeding for the healthy full-term infant. And I want to stress this is the healthy full-term infant. We want to be able to assist a parent with getting breastfeeding well established. We want to know how to assure that an infant is receiving adequate nutrition, and then be able to provide our parents with anticipatory guidance for breastfeeding concerns in the early days. And before we jump into our content today on April 16th, I want to address our current breastfeeding hot topic, which is breastfeeding and COVID-19. There is guidance available on COVID-19, pregnancy and breastfeeding from the World Health Organization, from CDC, American Academy of Pediatrics, the Academy of Breastfeeding Medicine, ACOG, and the American Academy of Family Physicians. From that information, we have been able to glean the following general information: that prenatal patients may be at higher risk because prenatal patients are at higher risk of an infection due to the bodily changes that occur during the pregnancy. We have no evidence to support mother-to-child transmission during pregnancy. We have no evidence that this virus, the coronavirus, is present in breast milk. The concern is the transfer of the virus through respiratory droplets. We know that breast milk is protective against infectious diseases that are prevented by the transfer of direct antibodies. We may see a temporary separation of parent and infant during their hospital stay. This could be done in the same room with the curtain separating the mom and baby and not having baby in direct contact with mom. The World Health Organization recommends that disruptions to breastfeeding should be minimized by enabling rooming in and skin-to-skin care. All patients should receive practical breastfeeding support from healthcare professionals, from peer counselors, and doulas. And a lot of this is being done remotely during this era of COVID-19. Here is some guidance from the CDC and the World Health Organization to help us as we work with our families. If the patient is sick and chooses to directly breastfeed their infant, we need to stress that they do frequent hand washing with soapy water for 20 seconds or use that alcohol-based hand sanitizers, and hands should be washed before and after touching the infant. They should avoid touching eyes, face, and mouth with unwashed hands. They should wear a face mask or cloth face covering over the nose and mouth while feeding the infant, and this prevents those respiratory droplets from getting on the infant. And should clean and disinfect all surfaces that are touched by the parent. We may have patients who are too sick to breastfeed or who choose to express their breast milk but want their infant to get that breast milk because of the protective antibodies. When we work with those patients, we work with them to have them express breast milk with the goal of establishing and maintaining milk supply using that dedicated breast pump. We stress to them washing hands before touching the pump parts or the bottles that they're going to use to express the breast milk, and that they should wash their hands after expressing breast milk. The pump should be cleaned and disinfected following CDC guidelines, and all surfaces that have been touched by the parent should be cleaned and disinfected. And if possible, someone who is healthy should feed the infant using necessary precautions. This is a graphic from CDC on how to keep your breast pump parts clean and how to clean those. On your resource list for this training, there is a link for this PDF. So you want to use this in talking to and teaching your clients or your patients. And then the guidance on feeding that express breast milk or a formula supplement to those infants. If a family is feeding that infant express breast milk from a bottle or chooses to use formula or needs to supplement with formula, this is the education that we should provide. They should wash and sanitize all bottles and nipples that are being used. They should wash and sanitize all breast pump parts. And when feeding their infant, they should use respiratory hygiene and hand washing, just like they would in the previous slides. And that they should clean and disinfect all surfaces that are being touched for pumping or feeding the baby or preparing those bottles. At this point, before we move on, do we have any questions?
Yes, I have a question. I was told that if a mother is coronavirus positive, that she can't breastfeed her baby.
Okay, so the guidance, and that has been said, that has been heard, but it's encouraging to see that our professional organizations are encouraging us to support breastfeeding with these families. The most recent one came out from the American Academy of Family Physicians, and they are stressing we want these babies to get the breast milk. But we may need to put into place some of the things we saw on these slides, that separation of mom and baby and using express breast milk for that infant and using the hand hygiene and the prevention of those respiratory droplets getting on the baby. But World Health Organization and all of our professional organizations at this point are recommending that infants receive breast milk for the babies. What do the professional organizations say? So in our normal world, normal healthy newborn infant, what is recommended by the professional organizations? They state that breastfeeding is the preferred, optimal, and normative way for feeding our infant and should be the standard by which everything else is measured. And their recommendation is for exclusive breastfeeding for the first 6 months of life, continuing to breastfeed till 12 months, with the infant being given complementary food starting around 6 months of age. With that as our base, let's jump into working with these parents to help them breastfeed their infants. First step is to understand milk production. All parents should be taught what to expect related to milk production. Throughout the pregnancy, the body has been getting ready to produce milk for the infant and is fully capable of milk production after 20 weeks gestation. With the delivery of the infant and the placenta, we see a rapid decrease in estrogen and progesterone levels that triggers the body to increase milk production. The first few days after delivery, milk synthesis is controlled by a decrease in progesterone levels, with continued high levels of prolactin and oxytocin. And the breast is going to make milk whether baby goes to breast or not. That's how our body works. It's been gearing up to make milk throughout the pregnancy. After the early days of breastfeeding, the removal of the milk from the breast is what controls milk synthesis or milk production. A full breast will signal the body to make less milk, whereas if the breast is empty, the breast will be signaled to make more milk. And this is the result of a whey protein called a feedback inhibitor of lactation. If the breast is really full, this whey protein is going to slow milk production down. If our breast is empty, the body gets the message, hey, we've got to make more milk because that level of whey protein is much lower. So we could say that breast milk production is based on demand and supply. Just like at a factory, the more I ask for a product, the factory for a product, the more of that product that's going to be available to me. That's the same concept with our breast. The more we ask it to make, the more it's going to make. Some good tools to help our families understand what's going on with milk production. On day one, the parent is producing somewhere between 30 and 100 milliliters of breast milk or colostrum. And colostrum is really important for the babies. It's that first milk. It can be yellow. It can be sticky. It may be clear. It's loaded with antibodies. It's like giving the baby his first vaccination, his first immunizations. It also has a laxative property to it that helps to clear out the meconium stool. And so think about moms only producing about 1 to 3 ounces on day one. Baby's stomach on day one is only about the size of a teaspoon and will only hold about 5 to 7 milliliters of milk at a feeding. And this parent here is expressing breast milk onto a teaspoon to be able to feed the infant. By day 3, the milk volume has increased to 500 milliliters a day. And this may be the time that you get the call from the parent that complaining of, oh, my breast is really full, it's hard, I'm having trouble getting baby to latch onto the breast, my nipple and areola are no longer soft and pliable. And baby's stomach at this point is about the size of a golf ball or a ping pong ball and will be holding somewhere around an ounce at a feeding. If that parent is feeding her baby on demand about 8 to 12 times in 24 hours, her infant will get enough milk or will get adequate milk production. By day 10, the infant's stomach is the size of a large egg and is going to hold about 2 to 3 ounces of milk at a feeding. And mom or the parent's milk production at that point has reached its full capacity of 750 to 900 milliliters, which is about 25 to 30 ounces of milk. Again, if we do the math, baby eating 8 to 12 times in 24 hours, taking 2 to 3 ounces, that we see that mom is producing enough milk for the baby. I want us to look at this picture right here. This is some express breast milk, and you'll notice here on the bottom, this milk looks kind of thin and watery. This is the first milk that the baby gets during the feeding. We may hear it referred to as fore milk. It's going to help the baby have those wet diapers we look for, and it's going to quench our baby's thirst. As the feeding progresses, the milk starts to get thicker, and we see this higher fat milk at the end of the feeding. And we want the baby to feed at breast long enough to get this high fat milk, which is going to help the infant to gain weight, have those frequent poopy diapers we look for, and to be content between feedings. You may get the call from the parent, I've expressed some milk, and when I left it sitting there, it's separated. Is my milk still okay? And the answer to that is yes. The parents just need to move that bottle back and forth gently to redisperse the fat in with the milk so that it's all like our milk looks from the grocery store, like the milk we buy from the grocery store, all homogenized and ready for us. Our steps to exclusive breastfeeding. Once we help parents understand milk production, we want to start to talk about steps that lead to exclusive breastfeeding. And the first thing to talk to parents about, this should actually start during their pregnancy, is start talking to them about skin-to-skin care and rooming in. In our baby-friendly hospital initiative, there's 2 steps that address this. With the skin-to-skin care, the recommendation is that babies be placed skin-to-skin immediately after delivery if both mom and baby are stable and able, and that the baby is kept there for an hour, allowing those primitive neonatal reflexes to kick in, and that baby to step and crawl and latch onto the breast for the first feeding. You may say, why is skin-to-skin care so important? It's important for the baby to maintain respirations, to stabilize their blood glucose level, to stabilize their temperature. It's important for mom because it keeps that oxytocin level high and is going to help her to deliver that placenta. It's going to keep that process going. It also helps to the baby's gut microbiome to get established because baby's there skin to skin to mom and getting that first feeding at the breast. And we know when we do skin to skin care and rooming in with our mom and baby, meaning keeping mom and baby in the same room throughout the hospital stay, that we see an increase in exclusive breastfeeding and the duration of breastfeeding. So this would be the first step to help our parents get started. And the conversation during the pregnancy helps prepare that parent for what's going to happen during the hospital stay. Then we want to start talking to parents and educating them about an optimal position in latch. You'll often get the question from our parents of, what's the best position? And the answer to that is, whichever position works for you, as long as that position is facilitating the infant getting an optimal latch with maximum transfer of milk. And we may find that the position that works really, really well in the hospital may not be the best position when that baby's 2 or 3 weeks old, because babies are growing and developing and constantly changing. Some things that we look for when we think about optimal positions are having that parent in a comfortable, well-supported position so that the parent is very well relaxed. I've seen parents come in hunched over, stressed, very uncomfortable looking, in a semi-reclined position works very, very well for that. The baby's body should be very well supported and should be turned chest to chest with the parent. And when we look at that baby, the goal would be to have the infant's ear, shoulder, and hip all in a straight line, with their head level with or slightly below that parent's nipple, or with the baby positioned with his head in between the parent's breast to facilitate the baby latching on. I have a short video on natural breastfeeding, and I'm going to let Nancy Moorbacher describe this natural breastfeeding position for you. And then we'll look at a few slides and walk through those. Wrong button.
Newborns need a lot of extra help in the beginning to get on the breast and feed well. And I think sometimes even with a second baby, mothers sometimes forget how much help a newborn needs. And so the natural breastfeeding positions just make it way easier for the baby. So I'd like to tell you a little bit more about some of the adjustments that you can make when you're using natural breastfeeding, because there's really 3 areas that we talk about adjusting. One of them is adjusting your body. And so, I showed you how you could do it in a chair, but why don't you go ahead and get adjusted here in the couch as if you were going to do a natural breastfeeding position. So just move your hips forward.
Oh, you do what I do. You go in right for the corner.
That's good. Okay. That's good. Okay. So part of the adjusting your body is figuring out, what angle you want to, how far back you want to angle. And you'll know when the baby goes on your body if you've got a good angle or not. One of the ways here, let me give you the baby. So for example, if the baby is resting comfortably on your body and is not falling away, then that's a good sign that you've got a good angle that's going to work for natural breastfeeding. Okay. So why don't you actually pull your hips forward a little bit more. Let's see if you can get a little bit more there.
Oh, that's a lot more comfortable.
Oh, there you go. So see, that's the other thing. Another part of adjusting your body is figuring out a position where you can relax all your muscles. So like in this case here, you can, now we have an extra pillow over there. Let me have that. I noticed that you're holding your arm up here. So see, that's something you don't want to be doing. So go ahead and lean back. If you're going to be using your arm as a head support for your baby, you want to make sure that you've got something under your elbow so that you can, again, relax that. You don't want tense shoulders, or tensed arms. So I want to try scooting forward just a little bit more and see how that feels. Is that good?
Oh, yeah.
Okay, good. Okay, so see, you'll be able to know from your own comfort. So adjusting your body is the first adjustment. And now the second adjustment is adjusting your baby. And that involves a couple different things. It involves, the baby can actually go to the breast from a lot of different angles. Now you've got your baby kind of straight up and down on your body here. But for example, if you move the baby so the baby's more diagonally, that's another angle. You could even move the baby over so the baby's resting on your other breast, so it's kind of straight across there. And if you've had a cesarean, obviously you would want to avoid having the baby's weight on your incision. You could even, and just to show us for fun, put the baby's feet over your shoulder. You could even have your baby on your body that way. Of course, that probably isn't going to be your first choice. Yeah. But any actual angle, because the breast is a circle, you could do any of those. And so some women find one seems to work better for their baby or for them. And some make adjustments even in the middle of the feeding because it just feels more comfortable to do that. So the other part of adjusting your baby is making sure that your baby has foot contact with something. So, for example, let's say the baby was on the other breast. One of the other options you have, here, let's bring the baby's body down this way. No, you stay where you are.
You stay comfortable.
Yeah.
First is
here, let me put this in here.
Adjust your body. Then we're going to adjust the baby.
So, see, this would be another way. If you had a cesarean, you could have the baby kind of coming off the side like that. But the baby's feet need to be in contact with either you or with something soft nearby so that we've got the pillow for that. Because when the baby's feet are touching something, then that helps to orient the baby and it helps to trigger the reflexes in the best way. So those are the two parts of adjusting your body and adjusting your baby. And then the third adjustment, which sometimes you don't need to use, is adjust your breast. And you can use breast shaping. You've got the breast models over there. Here we go. So for example, if your baby's like sort of bobbing around and having a hard time latching, what you can do is you can squeeze the breast just a little bit to make it easier. You know how when you have a sandwich that's bigger than your mouth, you kind of squeeze it down, so that you can get a better mouthful. That can help with the baby too. If the breast is really rounded and the baby needs you just to squeeze a little bit so that it makes it easier for him to get his mouth around it. So sometimes you might need that, sometimes you might not, but adjusting your breast. So adjust your body, adjust your baby, adjust your breast, and those are the three.
Do you just kind of make sure that it's all, I don't know how to ask this question. like you said, like adjusting yourself, like you would just gently put your hand there.
Yeah.
And that would just ease things for the baby.
It could, like just a little gentle squeeze
Okay.
might just make it easier for the baby to get his mouth around it. Because if it's a real, like this breast here is really round, and sometimes babies just kind of struggle to get a mouthful of it.
Okay.
And so if you squeeze it down a little bit, then the baby can get the mouthful just a little bit easier that way. So that would be the third adjustment.
If you are talking to a parent for the phone and trying to explain these positions, these videos are available on YouTube, so you can have them watch that. And I've done that many times because the parents can't see what we're explaining. If you're working with the parents face to face, here are a picture of the different positions, and I want us to walk through and look at some characteristics going back to our slide on optimal position. In this, which is the cradle hold, the position that most of our parents choose to use and like to use, a couple things to look for. This mom looks really relaxed, really comfortable, and you'll notice that the baby is also very comfortable. And if we talked about the ear, shoulder, and hip being in a straight line, and you can see he's aligned really straight, and he is turned chest to chest with mom. So we would go, okay, they're probably getting a really good transfer of milk in that position. This parent is using the cross cradle position. The baby is still in front of mom. We can see here that she's using a pillow to support her arms and to help hold that baby chest to chest with her. Again, you can see her little one has got her ear, shoulder, and hip all in a straight line. Mom looks like she's reclined back and very, very comfortable. This position here is your football hold or the under the arm position or clutch hold. I've got a couple of concerns about this mom and baby in this position. The baby is aligned really well. The ear, shoulder, and hip are in a straight line, but he might have a better transfer of milk if his chest was turned a little bit better towards mom. And then I'm afraid this mom's going to be the one who's calling me and saying, I've got some soreness and tenderness in my back and my shoulders. As you can see, she's kind of hunched over. So having her lean back a little more and pulling baby with her. Going back to this mom doing the cross cradle, she looks like a mom who may be a little bit larger breasted. And in that case, sometimes they're concerned about the weight of the breast on the baby's chest. So having that mom place a folded washcloth or rolled up hand towel under the breast to help hold that weight does tend to facilitate a better latch on and better position for the baby. This is an upright position. Some moms may use this. They find it easier based on the size of their breast or their milk flow. You'll notice this little one is chest to chest with mom. He's aligned pretty well. I might suggest that mom using this position pull a pillow right here behind baby's back to support her hand because her hand might get a little bit tired holding baby. And then here is our sideline position. You can see that mom and baby are aligned chest to chest. We do need, this mom doesn't have a lot of pillows, but usually when we're doing this position, we want moms to have some pillows behind them to give them some support. And maybe even a pillow here behind the baby to keep the baby from rolling over, but they're aligned really, really good. Our goal is to get an effective latch. So regardless of which position the mom uses or combination of positions the mom uses, the baby should have a big wide mouth, and you can see this one has a big wide mouth. The chin should come in and be touching the breast first. The lips are flared out. And I tell parents, if I'm talking over the phone, look for a mouth that looks like a big, wide fish's mouth. You don't want it being pursed up like a little rosebud or like baby's going to give you a kiss, but it should be nice and flared, wide open, and it should be asymmetrical. And by asymmetrical, we mean that there's more of this areola in the baby's mouth on the lower side than on the upper side. And what we see is that babies will get an effective latch if all of those line up. I've got 2 video clips that I want to show you. A couple things I want to point out before we watch each one of them. You'll notice this one. You can see how this baby's got his chin right there in the breast. Those lips are flared out. It's asymmetrical. And what I want you to do is to listen to this baby during the feeding. Then I want us to compare it to this baby. You can see here while his lips are flared, he's not quite as deep on the breast. The chin is kind of touching, but not as deep. And if you were to walk into the room where this mom and baby were at, or you were doing a counseling session with them, listen to what you might hear. And if you are doing what most people do who see that, they go, ow, this does not look comfortable. So those are things that you would look at to make sure this mom has an optimal position and latch for her and her baby. Before we move on, are there any other questions?
I don't have a question, but just a comment. It was very helpful to see in the video the different positions of the last tube. And in that first video, it was helpful to see and hear about compressing the breast, sort of like a sandwich. That's a really good thing to think about with patients.
It is. And that's one reason that first video we showed, if I'm talking to parents over the phone or even sometimes face to face, and I'm like, you really, if you need to look at something to help you, letting them watch that video at home makes a big difference because they may miss something during our consult. And hearing that triggers, oh, this is what I need to be doing. So thank you for those comments. We're going to move on. We've got baby latch, things are going well, but mom's just had her baby. Those early days of breastfeeding are very, very, very hard and challenging. And you may get a call from a mom, or you may get a referral to talk to that mom, and you call her and she's talking about how tired she is, how fatigued she is. You find out she had a long delivery that ended up in a C-section delivery, and she's trying to recover from that and take care of the newborn and a toddler, and the baby's asking to eat and queuing to feed really often, and she's like, I'm not getting more than a couple hours of sleep at night. So overall, she's feeling very, very overwhelmed, and with all of that, there's that increased risk of developing the baby blues, her feeling some depression coming on. So these are things that your parents that you talk to may be dealing with, and some strategies that may help them survive those early weeks is sometimes just hearing that what's going on is normal. It's really normal to feel overwhelmed. It's normal to be tired. It's normal to not get sleep. Stress to her to nap when her baby naps. Encourage them to limit visitors. I tell the partner a lot of times, you're the policeman. You're the one that is the gatekeeper. You can control who comes and who goes. And I've often told them, don't let somebody come in your house unless they've got some food or they're willing to fold some laundry for you guys. Accept help from family and friends. And that's hard for a lot of us because we want to be independent. We want to show the world we can take care of ourselves, but it's okay to accept help. Eat healthy foods and drinks. If you know your client is on WIC, help them process and think about, how can I use the foods that I get with my WIC vouchers to eat healthy? How can I prepare these foods ahead of time so that I can just go grab them out of the refrigerator and not have to worry about cooking? Limit activities. even if feeling well. Sometimes moms will go, oh, I'm feeling good. I'm going to get back into doing all my normal stuff. But she needs to ease back into it really slowly. It's okay to take a break from the things in our life that we've been doing. You've got a good excuse. You've got a new baby. And it's okay to ask for help with positioning and latch on. I've worked with moms who come in and they've been struggling with positioning and latch, but they haven't reached out for help until it reaches the point that we have to work really, really hard to correct what's going on and to get mom headed in the right direction. So encouraging her to ask for help during this time. One of the things that we can teach parents that will help with this transition and to being that new parent is to recognize infant feeding cues. And we talk about feeding an infant on demand, and parents a lot of times don't know what that means. They don't know what those feeding cues are. So helping them understand those early cues are the baby doing sucking movements or sucking sounds, doing some hand and mouth movements, or starting to wake up and have some rapid eye movements, or you'll hear literally soft cooing or sighing sounds, or you'll start to see that the baby starts to get restless. A lot of parents think that how they know baby is hungry is that baby starts crying. Well, if baby's crying, we've missed all of those early feeding cues. And the early cues is the best time to feed baby because it's easier to work with them and they're easier. They're wanting to learn what is going on. Um, Babies cry for lots of reasons. That's how they communicate to us. That's how they tell us, my diaper's wet, I'm too hot, I'm too cold, this outfit's too tight, it's too loud, it's too quiet. That's how they communicate. It doesn't always mean that they're hungry. So to help parents understand that, I think if we understand that babies go through about 7 states, and we're going to look at 4 of those, and they move between those states quite often during the day. And they may go back and forth really frequently, even within an hour's time. This little one is in a quiet or deep sleep. This is the time that's very restorative for our baby. And if we try to wake them up, it's going to take something very disturbing and intense to get this one to wake up, such as a toddler or an older sibling going in a room and banging together 2 pot lids may be what it takes to get this baby to wake up. They're not going to be very responsive. So if parents are trying to feed baby who's been in that quiet sleep or deep sleep, they can be very frustrating to feed, and parents will need to know, I need to wait till my baby moves to a different state. And the next state before that, when we think about those babies in deep sleep and we know our baby should be eating 8 to 12 times in 24 hours, and if mom has that baby that's in that deep or quiet sleep for a lot of the day, we may need to talk to her about waking that sleepy baby. And we do that by unwrapping, unswaddling, undressing the infant, holding the infant skin to skin. Baby can hear the heartbeat, smell the mom, smell the milk, and starts to stimulate those senses. Wake up. Change the baby's diaper. When we're holding the baby skin to skin, we can start to massage or rub their back, or if they're laying on our lap, rub their abdomen, their arms, their legs. That's going to stimulate the baby. Have a note there, itsy bitsy spider. That's just kind of the name we've given to walking our fingers very gently but firmly up the baby's spine, and it's kind of like a little massage, and it gets the baby to start to wake up, and it stimulates those nerve endings. And there's something there called the doll's eye technique, and this is if I take the baby from laying down to setting up and do it very gently, their eyes start to open and they start to become much more alert. The goal would be is to get baby to move to this active or light sleep state from the deep sleep. This is where our babies spend most of their sleeping time, and we may see them putting those hands to the mouth, the cooing, those early feeding cues with that. Sometimes parents will go lay their infant down. They'll think they're in the deep sleep, and they go lay them down, and they're actually in this active or light sleep, and they're starting to put their hands to their mouth, and I'm going, I thought I just fed them. They shouldn't be doing this. They're queuing to eat. And sometimes they're doing this to soothe themselves into a deeper sleep, especially if we know we just fed the infant. So if parents leave baby alone for just a few minutes, they may see them go into the deep sleep. They spend most of their sleep time in this state, and this is because their brain is processing and storing a lot of information, which is linked to learning. So this is the time when all of that brain growth is happening. And in this state, babies are really tuned in to internal and external stimulation. They would be able to know, oh, my diaper's really wet, or it's too hot, or it's too cold, or I'm starting to get hungry. The next state that they escalate to or go to is this quiet alert. This is the one that we all just want to pick up and interact with. And this is also the time that they're most responsive to breastfeeding. They're going to engage in whatever they see. If they see the nipple, they're going to engage with that. If they see a face or hear a voice, that's what they're going to interact with. They can also get very tired state because they're interacting so much. So a lot of times family may be visiting and baby's in this state, and everybody gets baby and is feeding baby or interacting with baby, engaging with baby. And mom goes, it's really time to feed the baby. And when mom ends up getting baby, baby has escalated to this crying state. So feeding baby is going to be harder because babies get tired and they're communicating, hey, I'm overtouched, I'm overstimulated, I got hungry 10 minutes ago and you guys didn't feed me. And when babies are in this state, we have to work with them to get them to calm down, to be able to eat. It's also remembering how they communicate that something's not right. So to calm this baby, we can swaddle them. That helps to get our baby recentered and refocused. You'll talk to parents who talk about walking up and down the hall to calm that baby. So swaddle them, walk, talk very calmly to the baby. And a good tool to use is Harvey Karp's 5S's to calm a fussy baby. Those steps are swaddling baby, having baby on their side or stomach position. So if parents are walking with baby, having baby's stomach to chest or chest to chest with mom would achieve that. Swinging, so kind of moving side to side. I think of an elephant swinging his head back and forth, kind of that motion of going side to side, doing a sushing sound. Shh, shh. That sound tends to calm the baby. And then making sure baby has something to suck on, like mom's finger, a pacifier, the baby's hand. A lot of times will help that baby to calm down. Then parents are always like, especially with breastfeeding, it depends upon what families are telling them, and maybe grandma who didn't breastfeed, they're saying, well, how do you know baby's getting enough? How do you know baby's growing? How do you know your breastfeeding is going well? So here are things to look at with our parents to assure them that breastfeeding is going well. Looking at their weight is one of the first steps that we do. Weight loss should be less than 7%. It's always good to find out what was baby's birth weight and what was their discharge weight. Because we should not be seeing weight loss after day 3. If we have a baby that we saw a lot of weight loss with that baby, that 7 to 10%, talking to mom about the delivery. Was it a long labor? Did she get a lot of IV fluids? Did it end up in a C-section delivery? Where research is showing us where moms get a high fluid load during delivery, those babies may lose more weight post-delivery. They should be gaining weight by day 5. and be back to their birth weight by day 10. If you notice, babies are gaining weight really rapidly the first 4 months of life. They're gaining about 2/3 to an ounce a day, which is 4 to 7 ounces a week. Some babies are going to gain the 4 ounces a week, and some babies may gain 8 ounces a week. So being aware that there's variations in there, that babies may not always gain an ounce a day. They may gain a little bit slower. Then you'll notice around 4 months of age that weight gain starts to slow down. It's then 3 to 5 ounces a week. And then after 6 months, it slows down even more, down to 2 to 3 ounces a week. Weight gain is a good way to let parents know babies are getting enough. The other things we look for when we're talking to our parents is how many times a day is the baby feeding? And it should be 8 to 12 times in 24 hours. Going back to our little clip of that baby with an effective latch, remember you heard a very rhythmic suck, swallow, breathe pattern with some very periodic pauses from the baby. And you heard those swallows. So by day 4, when we know the milk volume has gone up to that 500 mLs a day, or that 16 to 20 ounces, we should be hearing that baby swallow throughout the feeding. The other thing that we look at is the output. Babies should be having poopy diapers, and we look for that transition in the stool going from the one on the left, which is the dark tarry meconium stool, which the baby is going to have that first 24 to 48 hours after delivery. And if baby's getting that colostrum with its laxative properties, it's going to clear that out of the baby's system really, really fast. By day 3, when we see mom's milk volume increase, that's when we get this greenish brown stool, or that transitional stool. And by day 5, we should start to see stools that look like these two on the right hand of our screen. They're yellow, they're watery, they're seedy. And if a parent maybe has not been around a breastfed baby before, she may be calling you and saying, I think something's wrong with my baby. It looks like he has diarrhea. This stool looks so different than the baby who's getting formula. You may go, why do you have that quarter up in the corner of your slide? This is to remind us that the stool should be the size of a quarter or a little bit larger. Some parents will tell you, yeah, my baby has a poopy every time that they eat. But upon further, deeper questioning, it looks like just a little bit of mustard spread in the bottom of the diaper. So it needs to be the size of a quarter or larger, and they should be having 3 or more bowel movements a day. And this is in the early days and weeks of breastfeeding. As baby gets older, that stooling pattern changes. But in the early days, we're looking for 3 or more bowel movements in that 24-hour period. We also look at their wet diapers, and the picture here tells us that 3 tablespoons of liquid in that diaper is considered to be a wet diaper. And like this cloth diaper, it would be real easy to tell when it's wet. Sometimes our disposable diapers are very absorbent, and we may not be able to tell when it's wet. So having the parent put 3 tablespoons of liquid or water in a diaper to start to see how that gel feels, or having them put a piece of toilet tissue or Kleenex in the bottom of the diaper that they can feel that and know, oh, okay, this diaper is wet. You'll notice that we're looking on day 3 for 3 or more wet diapers, but by day 5, we're starting to see that increase in milk volume. We should be seeing 6 or more wet diapers a day, and those diapers should be, the urine should be very clear or pale yellow. It shouldn't look crystally or very dark in color. It should be clear and very pale in color. The baby should also be very satisfied and contented after a feeding. His hands get very relaxed during the feeding, drop down midline, he's very satisfied. And if we were with that mom and baby and doing a physical assessment, we would see that the mouth is nice and moist, and maybe even see some residual milk in the baby's mouth after the feeding. Parent signs of effective breastfeeding is that the nipple should appear very healthy and undamaged. It's going to look at the end of the feeding a lot like it did at the beginning of the feeding. It shouldn't be pointed, it shouldn't be compressed, it should still be nice and rounded looking. We have done parents a disservice by telling them that they shouldn't feel any pain. I think we need to clarify what we're talking about. The pain that the parent should feel is a very minimal pain that occurs when that baby first latches on and lasts only a few seconds. She should feel some discomfort in the early days of breastfeeding because this is something she hasn't done before. It's like us going to the gym after the first of the year, our New Year's resolution. I've got to get back in shape, and that first day after going to the gym or running, you're like, oh, what did I do? My muscles are achy. That's the kind of pain that the parent should feel. If she's feeling a pain that's making her hold her breath, her hair stand on end, or her toes curl, that's telling us we've got a latch-on problem. And this mother needs to be seeking help, calling to get a latch-on assessment, getting some help with positioning and latch-on. Parents should feel some uterine cramping. This is good anticipatory guidance to give them during the pregnancy, because if they haven't breastfed before, they haven't experienced that before, they're going to think something's wrong, because it's almost like feeling contractions during labor when that uterus, which was the size of your fist, weighed about 2 or 3 ounces at conception, now at delivery can weigh 2 to 3 pounds. It's cramping back down so the parent loses less blood post-delivery. They'll talk about feeling very relaxed, getting very drowsy. They'll talk about being thirsty. So we encourage them to keep a big old cup of water sitting there close to their nursing area so that they can get frequent sips of water throughout breastfeeding. And they're probably going to notice that milk is leaking from one side while baby is nursing on the other side. The other thing that lets a parent know that things are working the way they should is if we go back to our milk production slides, we talked about how around day 3, the parent should start to feel their breast being fuller, that increase in milk volume from 1 to 3 ounces a day to 16 to 20 ounces a day. And we talked about how the mom may call us and go, I can't get baby to latch, my breasts are hard, they're firm, they're painful. And this usually occurs by day 5 with our parents. And if we nurse baby, it should relieve that breast fullness that mom is feeling. But occasionally, this nipple and areola are so full and so firm and so hard that the parent can't get her infant to latch on. So we want to teach them how to do hand expression as a way to get through this time that might occur in the middle of the night. And it's recommended that we teach hand expression to all of our patients during their pregnancy, and that like last month during the pregnancy, and that we also teach hand expression while they're in the hospital so that they are equipped when they go home with the tool. So I'm going to let Jane Morton, who did all of this wonderful research on the role of hand expression in increasing milk supply, teach us how to do hand expression.
It is very simple to learn and teach hand expression. In the first couple of days, the average size of a good breastfeeding for a term baby is only a teaspoon. So all we expect to express each session is a few drops to a teaspoon. The more frequently milk is expressed, the sooner milk comes in and the more milk is produced. Partners can help if mothers are too sick. Mothers may find the following suggestions helpful. Have the mother sit up so that gravity is working for her, not against her. Use gentle massage over the breast with hands, a soft baby brush, or a warm towel. It'll help get the milk beginning to flow. Already we can see just with that, that just the massaging. Exactly, that's really good. Place fingers an inch away from the areola, making a C. Band-Aid markers make it easy to remember finger placement. I'm not going to get my fingers down here with a C. I'll keep them here so that the nipple is in the middle of my thumb and my pointing finger. Apply steady pressure inward towards the breasts, never massaging outward towards the nipple or the spoon. So back and then very gently together, and back and very gently together. And I don't expect to see anything in the beginning. So just know that in the very beginning, even when the baby nurses, she doesn't get anything. She's just beginning to sort of stimulate the milk to let down. And then, and the reason I just go very gently is so your breasts get kind of used to it first. And rather than stay on one breast, I go back and forth. So I go from the right to the left, and right to left, and back and forth. When I push back, I don't tighten up the skin, the dark skin. I don't pull like this. I just go straight back and together, and straight back and together. And then we'll get the milk flowing a little bit, and then I'll show you how to do it. And then we might as well start collecting a little bit.
Yeah, sure.
So remember when you try to do this yourself, that in the beginning, the milk didn't come very easily. And now it's coming very easily. Okay? Think of press, compress, relax. Press, compress, relax. In contrast to the breastfeeding baby, who, with her tongue and jaw, massages the ducts beneath the areola, with hand expression, we apply compression further back and deeper into the breast tissue. Press, compress, relax. Press, compress, relax. You make your hands really, really relaxed, and I'll do it for you, and I'll push back.
Okay, so that video is also available online, and it's one you can refer your parents to. They call you at 9, 10 o'clock at night and are stressed out. You can refer them to that video. Give them the technique to be able to hand express. One last question we're going to look at today is, should I supplement? And this is a question that we get often because parents are, going back to our milk production slides, are usually very concerned, is my baby getting enough? Should I supplement? Or the doctor has told them that baby needs a supplement in order to be able to gain weight. They're not meeting those growth parameters. If you get that call from the parent, assess why that supplement is needed and ask them, why are they asking for a supplement? What is their concern? What is going on that they're concerned about the baby getting enough? And really assess that situation with that parent. Assess breastfeeding. If she's like, I don't think baby is getting enough, and you're in a capacity that you can do a pre and post feed weight, this would be a good tool to use to guide your discussions with the patient to let them know, yeah, baby is getting enough milk, or yeah, your baby is not transferring enough milk and we need to supplement. One thing about pre and post feed weights, if you work in a health department in a WIC office, this does not fall within the scope of practice of a peer counselor. And also remember, if you're doing a pre and post feed weight at an office visit, this is just one snapshot in time, and mom baby coming in with a baby who's very sleepy. So you're not going to get a good feel for what a normal feeding would be at home. So do a good breastfeeding assessment. If we are going to supplement, the first preference would be the parent's own express breast milk. So making sure she has the good pump to be able to do that with. Is it a multi-user electric breast pump or one of our good single-user electric breast pumps? She may be, or she may come in and tell you, I was using donor milk in the hospital because baby wasn't gaining well. Or is the choice for this family to use infant formula? We also want to choose a method to supplement that's least likely to interfere with breastfeeding and that the parent is comfortable using. I've had clients come in or patients come in who were supplementing in the hospital and they're using a syringe and it's a week and a half out from delivery and they're struggling with using that. And we talk about what are you comfortable with? What do you feel is going to work for you and your family? And then we start with a small amount of the chosen supplement. Again, going back to our milk production slides where we talked about the size of the infant's stomach. The largest amount that an infant should be taking is that 2 to 3 ounces because by day 10, remember that infant's stomach is holding 2 to 3 ounces. So early on, they may be taking less than an ounce of supplement based on their stomach size. And if we're choosing to use formula, we want to have that parent prepare that formula correctly. There's guidance on the CDC website that the parent should use water from a safe source if they have well or spring water and they're concerned. They really should boil that water before mixing it with the formula. Use the amount of water that's recommended on the manufacturer's instructions. If it says to make 2 ounces of formula, that you use 2 ounces of water and a scoop of powder, you want that parent to know they need to measure that water first into the bottle and then add the powder. If they do not mix it correct and measure that water first, baby may get too concentrated of nutrients or may not get enough nutrients for proper growth and development. For infants that are under age 3 months or born premature or have a weakened immune system, we should take extra precautions when preparing our powdered formula to protect that infant against the chronobacter. And that goes back to boiling or sanitizing that water before we would mix it with the formula. Some guidance that comes out from our Baby Friendly Hospital initiative is making sure that parents know to not keep that formula at room temperature for long periods of time. They say not to keep it for longer than 2 hours. And if we start using a bottle of formula, but we don't finish it at a feeding, we need to discard that